and coming from a medical administrators, informed is herself to district level. She complains of shortness of breath since 4 to 5 years, palpitations since 4 to 5 years, and one episode of loss of consciousness 10 months ago. She was apparently normal 5 years ago. She noticed shortness of breath, incidence in onset. Initially it was NYHA class 2 started, gradually progressed to NYHA class 3 over 4 to 5 years. And the shortness of breath was used to be relieved by rest, and it was not associated with cough, fever, or diarrhea or seasonal variation. No history suggests no Hocm or PND. Also, she used history of palpitation since 4 to 5 years, which was exertional, initially class 2, started along with breathlessness.
So actually in the exam you can't say class 2 like this. You only interpret it. Finally interpret in history and interpretation, then you can say class 2 class 3. You don't know. Because you don't know how much you understand about class 3. Understand? So what do you say that? You don't know how much you know about class 2 class 3. So when you interpret after the end of history, you can say class 2 class 3.
No, I could go both ways. I could also say that if she's saying NYHA class 2, I could stop her midway and say, can you define what NYHA class 2 is? Yeah, so I mean it could be both ways. She could describe it and then I could ask her what is this NYHA. But it's okay. That's got a point.
Sir, in the same way, there was a question by one of the audience asking, should we ask for the gross scale or the NYHA?
No, last time was pediatric.
Yes, sir. The patient comes with the previous history, but the previous scale actually was asked. Because that was diagnosed at 7 years.
I am other cardiologists, I don't know about pediatric. I don't know.
So one of the people asked in the group, sir, should it be Ross grade or if the history starts with the pediatric? So they describe it.
It is in the pediatric age, no problem to this. Related to it. But now, if the person has grown up and he has come, then better to put it in the and you say that at the time of the cross 1 or cross 2, like maybe like born,
Along with shortness of breath, patient also used history of palpitation, exertional palpitation. She described as a regular palpitation, increases with activity and relieved by rest, not associated with any preceding chest pain like headaches or the palpitation episodes relieved by rest and not followed by diuresis. Since recently the palpitations she described as the change in the character of the palpitation. 9 months back, it was irregular, associated with the pre-syncopal episode, along with feeling of blurring of vision, lightheadedness, followed by one episode of syncope. And this was 1 year back. After that, her exertional palpitation continued with it. Only before the onset of syncope, it was she described as irregular palpitation and one episode of syncope. This syncope was not associated with any auditory hallucination, auditory disturbance, limb movement, but by prolonged post-ictal state or any body injury. No history of chest pain, no history of swelling of limbs, abdominal phase, no history of decreased urine output, no history of any skin rash, joint pain or fever. Since last month, because of these symptoms, she has consulted a doctor nearby and in West Bengal, and she was advised some medications and advised further cardiac evaluation. After starting of medication, she says her symptoms are partially better and no further episodes of loss of consciousness after starting the treatment. Past history, no history suggests of rheumatic fever in past, no history of any medical or surgical, no history of any surgical procedures. Personal history, bowel bladder, habits are regular, sleep and appetite is normal, no addiction. Patient is a known case of hypothyroidism since last 11 years and she is on regular medication for this. Birth history, she was the firstborn, full-term normal vaginal delivery in the hospital, birth weight 2.5 kg, no perinatal complications. Family history, patient is first in birth order. She has a younger brother who is 18 years old and does not have any cardiac symptoms or diagnosed to have any cardiac disease. Patient's mother has two siblings, one younger brother. Patient's mother's younger brother used to have, he is 60-year-old now, and he has history of recurrent episodes of palpitations and loss of consciousness, for which he was advised to undergo some tests and followed by some device. And patient's mother's another brother also has similar history, but he has been advised medical management. Patient's grandmother, she was found to be dead in a pond in the early morning. Previous night she was seen to be normal. At around 65 years of age. And paternal side, no history of cardiac disease. Menstrual history, she has irregular cycles lasting for 3 to 4 days, and the last menstrual cycle was 9 hours. Treatment, she is on.
Pedigree in the family.
Yes,
How does it fit in? Horizontally or it goes vertically?
vertically.
Like
Autosomal. Frequently, she is on 2 medications as advised by the physician and 1 medication for hypothyroidism. And both the medications she takes once a day.
No injection.
No injections.
Can you describe this one episode of palpitation followed by loss of?
Yes.
But that is irregular.
Sorry?
That is irregular.
The irregular palpitation followed by loss of consciousness. I specifically want to know how much duration of irregular palpitation was there before she lost
So
her
this
consciousness.
episode was 1 year back when she says she was walking during that time and noticed some kind of pounding pulsation in the heart, kind of irregular pulsation, followed by she fell down, she lost her consciousness. She does not remember for how long she lost her consciousness, but mother says soon she recovered. And there was no
She
history.
recovered the palpitation from heart.
So, no.
What about the earlier palpitation? You said they were exertional.
Yeah, earlier qualification before this episode, patient described it as exertional. When she does any walking or high activity, she used to get palpitation. And after
Gradual onset or sudden onset?
gradual onset.
Gradual onset.
Yeah, not early. And with rest they used to leave and never occurred at rest before this episode.
How do you know that the syncope is cardiac? What are the features of the cardiac syncope?
Cardiac syncope can occur at rest, and there will be recovery of consciousness will be very soon, and there will be no significant.
The most important point is when sitting on the bed or at rest, they have a syncope. How long a patient should have palpitation before they lose consciousness?
At least 30 seconds.
30 seconds only.
Do patients with atrial fibrillation lose consciousness?
So if it is a chronic disease, they are usually adapted. Sudden change in the heart rate, like acute at the onset of atrial fibrillation, they can.
As syncope. I'm not sure unless they have an associated pre-excitation or they have a fixed cardiac. See, by the 3 cardinal symptoms that you described, dyspnea, palpitation, and loss of consciousness. This is a very difficult subset to explain. Now, if I was to ask you to explain what the pathology, what is the pathology that you are dealing with, can you tell me what you are dealing with? There's a rational explanation to this.
I think in terms of
And how do you explain palpitation? Exertional palpitation.
if it is like aortic valve stenosis,
And how do you explain
associated
exertional?
aortic regurgitation.
So you are combining therefore and saying.
Yes.
It's very difficult to explain. Exertional palpitation and syncope is very difficult to explain to you. What else can you think of? Sorry, you were saying something or not?
And that is the pre-established concept. Pre-established concept.
I don't think
That is pre-established concept.
fixed.
Well, dynamic concept. Dynamic. Better to say dynamic. Just to be of a good option, dynamic concept. Yes, only special.
But she had initial exertional palpitation.
Exertional palpitation, how do you explain?
Because
Every time she exerts, she has an AF. Otherwise, how you can't explain? See, by explaining hemodynamic explanation, exertional palpitations with a more, kind of a gradual onset, gradual offset, or regurgitation.
Regurgitation.
Isn't it? With a fixed obstruction, unless you are now inclined to the pollution.
So in the setting of fixed obstruction, dynamic obstruction, I would think of associated with mitral regurgitation as a cause of
You mean hypertrophic obstructive cardiomyopathy with mitral regurgitation, which worsens every time she exerts.
mitral regurgitation as a cause for volume exertion of
No, but in hypertrophic cardiomyopathy, does mitral regurgitation cause a volume overload, at least in the initial stages? Yes or no? It does not.
No, see, what the meaning of migration? Migration, awareness migration, due to change in contraction,
rate
contraction. So, hypercardiomyopathy, LV, hypertrophic. You expect to contract vigorously, so then the contraction.
So just to be increased contractility.
Full concept, what is there? See, doesn't mean that every time you get volume over get contraction. There is a contractility, breathing, and weight. So, heart rate increases, contract increases, you have contraction.
That even ionic stenosis is possible.
For sure. For sure.
Contractility increases even in ionic stenosis.
But contract more intense happen. See, what happens is that your down heart down, your distance cost you get. Distance cost you get. So, it will contract, but your outer wall is closed with a non-obstructionist. That contract is not very effective. Here, very much effective because the blood goes out with the outer wall initial stage. There is no obstruction in initial stage.
So from the history of syncope, can you know whether it is a stenosis or is it a diabetes? From the history.
So, here the history, here you people diagnosis, different diagnosis. So, for me, I will give you a dynamic obstruction. And dynamic LV hypertrophy and LV requires peak output acceleration and production hypertension and so on. So, ultrasound I get it, and the breathlessness you can get it. No, what is the, I
fixed obstruction, sir. The syncope can happen during the exercise, and in dynamic obstruction it will happen after the exercise.
Because it takes time for the weak contractility, SAM, everything to develop. Then they will use it. Because they can cope up in the exercise.
So she exactly does not remember the actual events during the episode of syncope. This is what I could think of.
If you are thinking seriously in terms of a fixed obstruction, etc., did you mention about fatigue or anything?
No, she does not have this.
He doesn't have fatigue. Second thing is, you gave us a very detailed family history. So what bearing does that have on your diagnosis?
So it's by seeing that it's with high penetrance, like it has involved all three generations. We consider grandmother died because of arrhythmia.
Huh?
If we consider that her grandmother died because of some arrhythmia, that means all three generations are involved, high penetrance. Think of that case.
So you are ascribing that to inherited arrhythmia,
Yes.
not to any structural class.
Can it be an inherited rather than
Possible.
No,
But she
the
has
symptoms.
she has breathlessness and exertion palpitation, which more towards structural heart disease.
So at the end of history, what are your diagnostic possibilities?
Somebody she's reviewing about female 5 years history of process of gratification and exertion palpitation, one episode of arrhythmic syncope. The significant family history in the Bible, I would consider LVOT obstruction, more frequently dynamic obstruction, the form of hypertrophic obstructive cardiomyopathy. Also, I would like to keep aortic stenosis with aortic regurgitation, and least likely I will keep combine the condition like rheumatic heart disease and with mitral stenosis and regurgitation. But the syncope is unlikely.
what about particular?
Can have exertional palpitation, can have arrhythmias with syncope.
valve prolapse, which is associated with hernias, for which you will do a detailed echocardiographic surgery. And you can ask the later scientists ask you, what is the mitral valve prolapse? In which you do a detailed echo and pick up the substrate for the hernia, which is the one.
Annular dissection.
Yes, they are. If you open, what is the etiology?
So, in the younger age group, I would like to consider tricuspid aorta. Also, next one.
You can't think of extension only. I will think of extension only.
She never had a right hand failure symptoms.
I actually put your extension only. I mean,
So,
you
her
know,
contributions were initially exertional contributions. Extremely would have more aerobic sudden onset, abrupt onset, abrupt offset, and sustained aerobics. She had only one episode of symptom during that phase.
don't issue a link of.
And this also,
But it seems a cyanotic disease or an acyanotic one?
so it can present both with cyanosis and acyanosis. It's cyanosis is like a biphasic, so can be present initially, then absent in the later period can be a lethargic.
Okay, go on.
Especially
So with the family history, it's hypertrophic cardiomyopathy is seems to be your first time.
Nowadays, we consider all hypertrophic cardiomyopathy as one entity, or you would like to be specific to try to rule out many things.
So there are HSM phenotypes. They can be like storage disorder, infiltrative disorder. But if they have a significant possible pathological genetic mutations associated, then we say.
And the Roman
Otherwise,
adenoids also comes very close. Adenoid also comes
Yes,
very close.
yes.
It's a unique.
Examination. Patient is portrayed to alert, height is 155 cm, weight is 50 kg, BMI is 20.8 kg per meter square. No paralytic sinuses, nothing very controlled. No signs of rheumatic activity, infectious authorities, back and spinal normal, thyroid is normal, no multiple working. Pulse is 70 per minute, occasionally irregular, ectopics, apex pulse deficit is 8. And it is gently, non-collapsing, no radio-reading, radiofemoral delay, or peripheral persistent dilatation. Blood pressure is 90/70 in the right upper limb.
What do you mean by jerky pump?
Rapid upstroke. High volume,
I was.
but risk upstroke.
So if you have a occasionally irregular pulse, could be cannot be, can be, how do you diagnose? How do you know which is responsible? How do you know if it's BBC or CBC or
Apex pulse deficit feature. More than 10 millimeters is less than 10.
It is a modern method of effects pulse width. Like single is well known.
So we put the step over the apex and also count the pulse. The number of missed beats at the radial so it is the gives the
And you can do all the pulse oximeter help. Sometimes you pick up the irregular pulse. So let the pulse oximeter do it. And do the oximeter.
You have the first step was regular, irregular.
so occasionally it is irregular.
What happened in that first step after the how do you make the effect on the
Actually, I can do this.
post it to write the first burning it. Post it.
Post is like a lower running post it.
Post it to write the first burning it. You normal what happens? Normally you post it to
It will be high volume.
here what happens?
And
You are not giving information back. You are not giving information. Through this patient, not seen. That way not considered.
JVT?
so this first
No, no. How do you know if it's BBC or AM No, that's the diagnosis.
Accreditation is not very AOL.
No, I do.
And JV, in between coming ectopics, it will collide with the ventricular history. What happened?
First negative descent
Diagnosis even gradual based, empty bag was, the bag was only telling me.
Okay, dots. Okay, dots.
You are the wrong side.
What is wrong?
Wrong side.
Wrong side.
Anybody can? Anybody can?
Maybe nothing or maybe one more thing before you go. Where do you see from pulse wave contour? Which part of that is? Which part of that is? Where do you look for vascular disease? No, no. You can see that. Basically, you look for down the left. And which is the part which is better to radial than radial rather than pulses
Physically measured pulse measures. What do you clinically measure example? How do you count pulse?
and also consider the regularity simultaneously. And we found the number of missed pulses in the radial artery. Which
What is the base pulse? It's impossible to count the pulse.
difficult to measure.
Can it be done by two examples?
Yes, sir.
JVP was normal according to you, can go on.
Serious examination, inspection and palpation combined. Chest is bilaterally symmetrical, no stars, and especially no steroids, no obvious visible pulsations. Apex is the visualized in 60 intercostal space, confirmed by palpations, LV apex in left 60 intercostal space in mid-clavicular level, hyperdynamic in nature.
Hyperdynamics.
Yes, sir. No particle axons, no particle dust, no parasternally, no rubber splits or tails. Percussion, left heart border transverse cortex,
What do you think more up?
click, no particle plates. Percussion, left heart border response cortex, right heart border substance.
So now what information do we have? Before you
So, by inspection palpation, there appears to be pelvic apex with hyperdynamic nature. And there is no palpable signs of pulmonary hypertension.
They may be hyperdynamic pulses. Hyperdynamic.
Yes, sir.
And pulse character normal pulse. So, high volume pulse. Jockey pulse. Okay.
one more two.
Any pathway stored on there? Nothing.
No,
Some of the cycle comes from there, you get.
How do you look for a variable?
During inspection, it looks like two prominent
Inspections were very, I mean, you have to be very fortunate to make any conclusions about the effects on inspection. Palpation.
if normal apex, we can see with one finger. Here it is with two fingers, both the fingers we can see the same amount of lift. With fingers spread apart.
No, I said
Separated by the normal
when we started in examining, we were thinking of some kind of detrital rototabs obstruction, possibly MMA or ASAR everything. Now that we have examined till auscultation, where are we further in terms of refining the diagnosis? From your findings, the apex in the left 6 space with this hyperdynamic suggests what? Hemodynamics. LV volume overload. Very good. LV volume overload. But your pulse pressure, your blood pressure is 90 by 70.
No sense of hypertension.
There is a narrow pulse pressure, if anything. So how are we putting all this together?
What is hyperdynamic? How do you hyperdynamic? How do you mean? How do you hyperdynamic involve?
The LV applied, you fix the finger but it is not sustained. Forceful but not sustained.
How much area?
More than 2.5 centimeters square.
Where?
Centimeters square. Yeah, if it is like more than 50% of the time, the lift is more than 50% of the systolic time, then it is sustained. We call it a healing. Less than that, hyperdynamic.
So as Dr. Prayag pointed out in the morning, this is entirely a learning session for all of us. We also learn this. And he just mentioned Dr. revered and late Dr. Rajan Tandon was professor and head of the department finally at the Royal Indian Institute, pediatric cardiologist of extraordinary eminence. He was also my DM examiner. He would write down every word you said. Okay. Everything that you said, you could write down. And if you were in a hurry, he would tell you, slow down, I'm an old man, and he would write slowly. Once in a while, you suddenly see his hand making 2 circles. You understand? That meant something which you said somewhere and something which you said later were not concurrent. Okay? It is a very good practice to do this to your own case presentation. I'm not finding you're doing fine. But when you write down your findings and everything, you read it again and look at it critically, not that what I have written. Imagine it is written by a third party and look at it and analyze it, you will find a lot of contradictory findings. It happens to all of us. In which case, you go back and verify first whether your finding is correct, or you start wondering, how do I explain this?
Yes, I thought they're not matching, but I would like to.
Fine, they're very good. That's good, but I'm saying in general, if you do this, very often if you do it before you appear in front of the examiner, then at least you either resolve the controversy or you start thinking of it. Continue.
Apical impulse. You use some terms which is a little confusing. What is double apical impulse? A double apical impulse is double systolic apical impulse or this is S4 plus an apical impulse. No, I'm just saying. So in that case, if you are not sure, use the term bifid apical impulse. That's enough. Bifid would mean 2 peaks in systole, or it will also mean S4 and 1 peak which you are associated with. So that also can be proper. So here it is, nothing is
Has the terminology forceful ill sustained and forceful well sustained gone out completely?
No.
Because actually the terminology is forceful well sustained, forceful ill sustained. So you probably say that it's so much easier. Terminology, hyperdynamic and all that. Your cause is forceful ill sustained.
Hyperkinetic is simply hyperkinetic and that's leading us to the, I think there are multiple giving these also. Am I correct? I have, yes, hyperkinetic, even Broadwald I think uses hyperkinetic.
Both are correct.
Okay, again, okay. So, fine. So now, when you auscultate, now what are the possibilities you are looking for?
I thought I kept in mind 2 regurgitation. I will take regurgitation after. But since my pulse pressure is not there, I have considered, I think
Okay.
So, profession, left heart body response to this, right heart body is parallel. Hemodialysis is there in fifth intercostal space on the right side. Gastric emptying is on the left side. Second space, left space is there. Auscultation, heart sounds. S1 is soft. S2 is normal, normal split with normal split with normal intensity of atrial fluid. LBS4 is there.
Okay, English for the lens.
No other reason. Coming to murmurs, there is a pansystolic murmur at the apical area, grade 3, uniform intensity, which frequency is radiating to axilla. And there is a systolic murmur which is harsher than the apical murmur. This is in the left third intercostal space, parasternally, which is increases with expiration. And on dynamic auscultation, the murmur increases with pulsar strain phase and static, and decreases with squatting.
No, you can take timing murmur. You see, first basic murmur, two sequential murmur, doesn't it? Murmur, the 5 sequential, there 4 transitory, aristotely, vertically.
So, the second murmur in left third intercostal space was also pansystolic,
Customer here.
but a harsher character than left third intercostal.
It doesn't have a crescendo, decrescendo.
No.
But consistent murmur there.
Consistent murmur is okay. So what is it? It's a PR.
Three, no, it's
Still not there. For Haxodani, apical murmur.
harsher.
Okay.
So what do you think? Is it PR murmur?
Really, I should think of basic murmur.
One minute. It is a pansystolic murmur.
Yes.
So what is the mechanism by which, in general, how are pansystolic murmurs produced?
She's not telling the concept.
Apex, there is a pansystolic murmur.
Okay. So what is the mechanisms by which a pansystolic murmur is produced? Hemodynamics.
So regurgitant lesions.
Okay. Regurgitation from the ventricle to the area. Cellular valve regurgitation will not produce pansystolic by any stretch of imagination.
Yes.
So regurgitation from ventricle to atrium or
Or communication between two ventricles of different values.
okay, good answer. Okay, the communication between two ventricles at different pressures. Fine. Okay. Now, doesn't this fly a bit in the face of all the diagnoses that we were coming through till now?
You always take out the findings. You told person serve, second one normal speed, normal intensity, S4. Remember your told S4. No, S4.
Yes.
No, remember S4 is almost always pathological. So S4 told and transformer here and here.
Apical area.
So you can't stand there. Transformer here and transformer here and S4 never.
Okay, we will not presume the diagnosis, but you explain it to us. What do you think is the second pansystolic? First pansystolic murmur, we understand. Second pansystolic murmur, what do you think is the pathology there?
It's the obstruction in the LVOT.
So does it cause a pansystolic murmur? Pansystolic murmur originates when the difference between the receiving chamber and the transmitting chamber was throughout constant, isn't it? Whether it's LB to LA, whether it's LB to RB, the pressure variation remains constant. Ejection systolic, on the other hand, varies with the systole. So it always should have it may be a long ejection systolic murmur, making you feel that it's a pansystolic murmur, but it always has a crescendo, decrescendo nature.
Sorry, what is the first pansystolic murmur?
So that was in the apical area, sir. Grade 3.
No, wait, what is the mechanism?
So I thought it was because of mitral regurgitation.
True, but just like he just now said, see, valvular mitral regurgitation due to a problem in the mitral valve, let's say rheumatic mitral regurgitation, will have a pressure gradient between left ventricle and left atrium throughout systole.
Yes.
What happens in hypertrophic cardiomyopathy? Does the mitral regurgitation start with the first cut one? in HCM.
No, sir. No, it does not start with system.
So then, though it is within court's final registration, you cannot apply the rules of normal right registration here. No? You understand that? Okay.
Now you have the advantage of the psychotherapy in this case. Will it help you to differentiate the normal and the third stage? The normal in the third stage you are saying is transitory. This irregular, you have an advantage in this case of having an irregular pulse. If you auscultate, you are able to always feel the irregularity. So how will that help you in telling whether it is a transystolic murmur or if you are missing a mid-systolic murmur? You are always thinking about HOCM. And you expect a mid-systolic murmur. So I am mistaking the murmur in the third phase as transystolic. How will the irregularity in the pulse help you to differentiate?
Post particular ectopima, there is a prolonged diastole and increase in field of LV cavities enlarged. So I would expect HCM murmur to decrease with post PPC.
All alphabetic murmurs, posted will increase. Alphabetic increase, whereas
Murmur will increase, but MR.
MR, what is MR? Second file.
So now, MR is primary valve abnormality or by SAM or collapse. So the murmur you can assess. So what will you do to differentiate between the two? So the same dynamic auscultation applied to the mid-systolic murmur, applied to the MR mode. If it behaves exactly the same, then you know it is caused by the SAM also. And in dynamic auscultation, particularly when you are doing diagnose, so in the falsafa maneuver is very difficult to do in Indian patients. They may comply or they will not comply. Yes, it's called stand, squat, stand. And the examiner also has to do that.
Yes.
So you have to stand with the patient, listen to the murmur, squat with the patient, listen to the murmur, and again stand with the patient and listen to the murmur. This procedure, you want to get combined with handle, but it's not really done. So stand, squat, stand. It's a real good method. Of course, otherwise also important. But this is the murmur that is going to differentiate. Because by that we are already, as Dr. said, preload, afterload, contractility, heart rate, all four are ordered by this deliver, and the murmur will behave in the standard hemodynamic manner. So what is the MR property?
Go on.
Other system examination, RS is not.
So in the time, one thing that it is seconds of normal equation, it is exclusive. You know the exclusive kind of study. If you normal seconds of normal, you can say normal speed. The exclusive study of the signal kind of study. Seconds of normal, they get it. It is normal, no seconds.
No, but meaning no offense to the candidate. A lot of candidates say the simplest way to answer about the second round sound is to say that it's fine. I mean, that is a fact of practical life. Okay, go ahead. That's all right.
Acquired heart disease, hyperventility obstruction with mitral regurgitation, with continuing class 2 and
Why do you want to get yourself into trouble by saying acquired heart disease? Why do you have to? Morning, Dr. Balchandar mentioned that in hypertrophic cardiomyopathy you have this confusion about whether you call it congenital. I mean, it's not acquired, right?
Whatever it is, and it's
Like you said, use the term structure.
You tell primary macular, going to get our primary macular disease.
myocardial involvement, dynamic obstruction, and hypertrophic obstructive cardiomyopathy with mitral regurgitation.
to show it
Yes.
how the history. Clinical. Based on history and
History wise, question is
history you have to
sustained.
How family history is government everything you have to examination.
Obstructing vaccine with outflow plasma.
Severe.
Resting obstruction.
That is what they are saying.
Heavy is cold.
Second time?
Second count is body in that. What are we looking for? If there is a severe,
Narrow.
again, don't take it. I don't explain. What happens in severe cases? If that severe is, you know,
Late,
Okay.
So, different paradoxes, you have to look for paradoxes.
even in air, you have to look for. So you have to look for paradox.
Now I asked you before, we went back to the bifid apical impulse. Now you said there is an LES score, but you said that there was only one impulse at the apex. So did you do anything after you heard the story? Anyone? Somebody just pass the mic.
LBS score is best started in the left lateral position.
Yeah, one is to put the patient in left lateral and very, very carefully look for, and it may you, see, don't expect that you will get two peaks, means that it will be like two mountains next to each other. It may just be a slight, shudder on the upstroke or on the downstroke. You don't know which one is the first, then you have to time that everything. But it would be unusual not to have that if, assuming that, I haven't examined that, assuming that all your other findings are correct. Okay, any other diagnosis? Okay, fine.
So, put it to mitral prolapse.
Matter prolapse.
Another question.
I could not hear the things.
You to constitute or not, immediately with modulation.
So if multiple products, they will get followed by one.
No, constitute, how should you do that? No, how should you do that?
He's saying the mitral valve prolapse with holosystolic prolapse and regurgitation throughout physically.
Why not?
So what else besides the absence of a click we are letting go? Can it still be mitral valve prolapse?
Yes, for don't get. Yes, for
Don't forget the family history. For every other differential diagnosis, you have to account for that family.
What's the question again? Listen, you have a paradoxical state of second heart, so how do you know which is atrial and which is clinical? Order is P to A to go. Paradoxical is
Coincides with the carotid.
P2A2 is the order now because it's paradoxically split. Okay, expiratory split on the second heart, so almost becomes single on inspiration, paradoxically split. How do you know which is P2A2? Now, this is called inching technique of the stethoscope. You go to the down, but people are using down. Inch your first identify the two sounds in the second left across the screen. Inch your technique. See the first component, see the second component. Come down to the apex. P2 will disappear in the apex. So if the first component of the split sound disappears in the apex, you know it is other than PA. But it is P2 because A2 is only heard in the apex. P2 is not heard. So the first component disappears, it is the first component is P2, the second component is P2. Then come back again to the apex area. See which component disappears. So that way you can make the paradoxical.
One thing asked, you answer very well. I used to ask, Cardiovascular speed per feet allowed, do something there. Cardiovascular speed per feet allowed. Three, correct.
Okay, can I ask you a question? Have you ever convincingly heard a paradoxical speech? How many people in the hall?
Not in the front row, beyond the front row.
Okay, see, she has heard it, somebody else there saying they've heard it. Believe me, the phenomenon exists. You have to auscultate carefully and know where to look for it. Okay, it is completely meaningless to just read in a book that there is something called paradoxical split, and then when the rest of your diagnosis sounds like paradoxical split, you slip it inside as part of your findings. Okay. If you listen, auscultate carefully in relatively young patients who are paced, very often you will be able to make it out, because in them both components of the second heart sound are heard. Okay. So don't think that this is something which is just written in books and elderly people sitting on the podium talk about it.
And don't read Abrams and get confused. There's type 1 paradoxical split, type 2 paradoxical split, and type 3. So don't get confused. What we are talking is classical.
You want ECG or X-ray? ECG. Okay.
Dr. Das, your question, loud P2 with paradoxical split can also happen in dilated cardiomyopathy, left bundle branch block PH.
Sure. Because of PH.
They are more common actually.
ECG.
So for these standard execution, normal sinus rhythm with in between particular ectopic beats. Humorous axis is around 90 degrees.
Does it fit with your diagnosis of hypertrophic cardiomyopathy?
First, you finish the findings of the ECG.
No cues in lateral release, no volume overload, which is healthy.
No, what is there? Okay, give me two figures here.
Again, enlargement, negative terminal in V1 appears to be problem.
Is this criteria is there or not? What is RKBL?
Use the common criteria.
What is RKBL?
Any comments on the rhythm?
So predominantly it's in sinus rhythm, sir. In between there are ectopics.
No, the question is what ectopic, no? But there are ectopics that the ECG is shouting out, but what ectopic?
What is the first complex related to?
Tell me, the lead one, who is the ectopic one? Which one? Lead one, see the lead one, who is the ectopic? First, second, third, fourth, which one? That is ectopic, that is normal.
That is not.
That is not.
Yeah, you see the PR is slightly shorter in the first complex. The first and third to RS are very similar. Maybe the first one is giving a bit of fusion.
Again, the fourth QRS from the end. From on the other side, you start counting backwards, the fourth QRS. No, I don't agree that these are ventricular.
No.
QRS is narrow.
Narrow thin section of the better test.
But remember, in practice, later on, you must get these topics clearly because you should know from which part of the left ventricle and there's a lot of immense potential in the treatment. For example, apical cardiac, hypertrophic cardiomyopathy, if you see the ectopics are coming from the apical region, not the LV.
Yes.
So it has a lot of significance. So you must analyze the ectopic and see from which side it is arising. May or may not be possible from ECG, but you have to think of it.
Now it becomes I don't know if these were the ectopics that were heard in the muscular patient because there doesn't seem to be much change in cycle length here. Okay, so may not necessarily be very useful in your. Okay, fine, this is the ECG. So now what else do you want?
What this one? X-ray.
Now 1 minute. Now with this ECG, would you expect any other AVP finding?
You must get anomaly because P and PS diffuse. You must get anomaly.
See the fourth complex from the end. The P wave and QRS are almost simultaneous. And even in the first one, somebody pointed out that the PR interval is, and the third P wave in the strip itself is missing, so most probably it is superimposed on the QRS. Okay, so you would expect that occasionally you would see Canon waves. Again, like I said, now that you see, if it was in regular practice, if you see the ECG, you should go back to the patient and see it's possible for anybody to miss it the first time, but you should go back and look for it.
Again, once more, in ventricular tachycardia, you have normal first heart source and normal JVP. What is the diagnosis? Patient is in having ventricular tachycardia, so the first heart sound is normal and the JVP is normal. Yeah, right. So VP with 1:1 retrograde catheter.
1:1 VA should produce regular Canon waves. P-wave is occurring during ventricular systole. No, we are saying regular 1:1 VA.
Just explain to you, central slightly overexposed central swing. There is LVL complex.
It's normal.
There is RS version. And augment RP delay.
Essentially all right.
Again, doctor, why get into RA and darkness? Is it impressive on this X-ray? You count the number of intercostal spaces. Now, nothing that we have said so far had anything to do with the right atrium. Huh? Don't make life difficult for yourself. Okay.
Unless you want to go back and say that Mohammed is right.
Don't get disheartened. I'm just saying, somebody else is.
Our questions are now gone into a little higher level.
No, that is one
Really
thing.
happy.
Second thing, like somebody said in the morning, I mean, it is the examiners who are the problem. Okay, fine. But do not help them by giving the, he mentioned a cricket analogy, don't throw easy balls that can be hit. Okay.
Along the looks thickened endometrial septum, and also posterior appears to be thickened. During systole, the cavity size is minimal. There is a contact of AML with the septum and mildly dilated.
What else do you need after this? Do you need an MO after this?
Yes, sir.
See what?
The data
Very
Management.
we start with beta blockers, sir, and avoid stress activity and avoid dehydration.
The echoes are all there. Nowadays, what else you need in an HOC in echo? You need it for many cases, but what else you need? No, you've got 2D, you've got another, you've got what else you need?
In echo. Any particular type of echo. Anything else you need?
Spectral tracking, GLS, is it more important or it is? GLS is important because the ejection fraction may not be active. It is the hypercapacity. As in what? Minus 15, minus 12,
Minus 13.5.
minus 13.5. And what about the remote echo in HOCM? The intraventricular septum moves flat. The left ventricular posterior wall is hypertension. In which condition, the intraventricular septum is hyperkinetic and the left ventricular posterior wall is flat? Which condition? Which one? It's also a cardiomyopathy, but not found in India, not found in Africa, not thoracic cardiomyopathy. Just
Just was the Doppler. Yes. The Doppler. I went on to management, but then
It's a dagger-shaped curve, such as binary obstruction.
Here is mean pressure important or peak pressure important?
we have a Doppler with you know.
So, since lady is ready,
Yes, sir.
it's not you pregnant, what is your advice? Marry and pregnant, so what is your advice?
Exact systolic function, sir. Systolic dysfunction.
Upper function, this patient looks upper normal, this patient is upper normal looks.
So basically, maybe now will be like to do to know the
What happens
if every
to-
dysfunction is there, then it becomes class 3 WHO. I got that.
What happens to blood volume in pregnancy?
Plasma volume expansion.
If plasma volume expands, what happens to the left ventricular outflow? Okay? Obstruction decreases.
So only I think the guidelines say to graduate more than 100 millimeter mercury, so probably will process. That otherwise, no issue. Only if you have this counsel that your 50% of children will be like this.
Would you like to recommend an AIC?
So we want to estimate the other parameters in shape and high risk than
And then the super now. Why the
And
information?
she had one history of syncope, which is probably a disease. Yes, sir.
Calculator. You have this calculator on the net.
Yes.
It is there by AHA. There is this calculator for ESC by European Society also. So use this calculator. Definitely you put a ICDP. But otherwise you use pure derivatives instead of this calculator and all that. So diastolic wall thickness you should know. Diastolic wall thickness and
More than 30.
because of the family history, get a, if possible, done in general, get a genetic thing for NYHC.
Everything has been not grown in this country.
Genetics is actually now, Reliance is taking over one lab and it's very cheap now, it's some 60,000.
No, 100 years old, it's not biased, I don't think it is. So, this is the criteria.
NYHC mutation, probably is one of the other factors to be included.
Genetic has a role.
How many mutations are associated?
But in her case, I think the family history of syncope preceded by calculation, I think
I think you request, especially.
she requires an answer.
Last week, there was about
No, okay, now she doesn't tolerate beta blockers. And what dose would you give the beta blocker? What dose? Anyway, think about it. Okay, she doesn't tolerate beta blockers.
You can change over to calcium channel blockers or you can start bisulfite.
No, which calcium channel?
Bisopyramide we can consider if there is no response to monotherapy beta blockers or CCBs.
Any other newer drug?
Navacamptone has come, sir. So myosin ATP is orally
explore that.
explorers.
So, just evaluate her and then we will.
Because we are asking a lot of questions, goes without saying that you have visited well. Only thing you should not get confused in the basic thing of file system. That is one thing which perhaps we will be able to, but little bit of problem. Otherwise, other things you answered well. And I think at the end of, you are at the end of third year or? So you are already well prepared as far as the HOCM is concerned.
And I'm always
Qualified HOCM qualified DNP.
One point, I mean, just because this patient had syncope, the correct pronunciation is syncope, systole, diastole. All three you got wrong. So I'm just saying, and not only you, most people say systole, diastole, and syncope. That is not the correct pronunciation.
I thank all the examiners. Thank you, Shruti. I request Vikram to just give her a small table of appreciation. Yes, sir. Yes, sir. Please.
Means syncope and sudden death in this context.
No, what is the relation of syncope and sudden cardiac?
See, the setting of structural heart
Unless
disease like
syncope
this.
is a risk factor for sudden cardiac.
It is a quotation often ascribed to Eric Pistovsky, although actually somebody said it before Eric Pistovsky. The difference between syncope and sudden death in conditions like this is that in one of them you wake up.
I thank Shruti for this case. We have now the